All right. Thanks for having me. I'm going to be talking about MASLD in type 2 diabetes today. And just to give you a little bit of my background so you know what perspective I'm coming from, I am currently the chair of family medicine at the Warren Alpert Medical School at Brown University and at the Care New England Health System. Before I came to Brown 3 years ago, I was actually at the University of Michigan, and I was one of the directors, the founding director of MCT2D. So I was involved in the MCT2D program for many years. I was also a co-author on the ADA's recently released MASLD guide consensus statement that was released at the end of 2025. And that is mostly what I'm going to be summarizing and going over the details of for you today. I am a primary care physician. I see patients in primary care. I do a lot of diabetes care. I'm also the editor of Annals of Family Medicine, which is family medicine's primary research, original research journal. And as I said, the founding director of MCT2D. So I will be coming at this talk a little bit from the perspective of a primary care physician, but mostly focusing on the basics and what we need to do for pretty much every person with type 2 diabetes with respect to liver disease. So step one is to go over some nomenclature, mostly because it's changed. They changed all the words, and now it's pretty confusing. I think the new words are better, but it's still a translation that we have to do. Those of us who were trained 10 years ago heard a lot about NAFLD, NAFLD, and NASH. NAFLD and NASH are no longer terms that we're using. The primary reason for switching from NAFLD and NASH to MASLD and MASH is that NA stands for non-alcoholic, and the idea is that focusing on the non-alcoholic sort of diagnosis of exclusion. If it's not alcohol, then this is what it is, rather than focusing on the actual etiology of the disease, which is metabolic associated steatotic liver disease. So moving from the N to the M, from non-alcoholic to metabolic associated is the main change that's happened here. But there's a few other changes that have happened as well. There's a new category of steatotic liver disease called MASLD, which is metabolic and alcohol-related liver disease. And often this MASLD group is not the severe alcoholics that you might think of, who normally have, end-stage cirrhosis, but even relatively modest amounts of alcohol combined with metabolic liver disease can be pretty high risk for cirrhosis and fibrosis, liver failure, and hepatocellular carcinoma. So MASLD is a new category. It's about 10% of the people with MASLD, according to current statistics. And then, of course, there's alcohol-associated steatotic liver disease, which is has not changed its name significantly, but it's still one of the major causes of liver disease in our country. There was a lot of talk, even in our paper that we released in December, that metabolic liver disease had become more prevalent than alcohol-associated liver disease in the US. And it was on track to be true, but because of COVID, people started drinking a lot more, and alcoholic liver disease increased in its prevalence. And so MASLD has not yet surpassed alcohol liver disease according to most research, but they're pretty close, and it's a high burden, and especially when they're both present, it's a very high risk. So why do we care about MASLD and in diabetes? And the main reason is that 70% of people who have type 2 diabetes have already signs of liver disease from metabolic dysfunction. When we talk about screening for liver disease and diabetes, we're really not screening for MASLD. We kind of already know they probably have MASLD. So what we're screening for is more advanced fibrosis. After more advanced MASLD would be MASH, which is steatohepatitis, or inflammation related to the steatotic liver disease. And then after MASH, you get to the advanced fibrosis. And advanced fibrosis is pretty significant. It means scarring of the liver from steatohepatitis. And 1 in 5 people with type 2 diabetes already have advanced fibrosis. So it's pretty common. Advanced fibrosis can transition into cirrhosis, and then it presents a very high risk for hepatocellular carcinoma. So both alcohol and MASLD are primary causes of liver transplant and death from liver failure in the U.S. We have an annual rate of about 12,000 liver transplants in the U.S., 30,000 hepatocellular carcinoma cancers detected, and 52,000 people die from liver failure. So these are not rare events. They may be more rare than some of the things we worry about with diabetes, but they are, cardiovascular disease, of course, is a much bigger, more likely to cause death in a patient with type 2 diabetes than liver diseases, but it's not rare. We estimate about 2 to 3 liver-related deaths per 1,000 person years with type 2 diabetes. So if you take care of a substantial number of diabetes patients over time, you're likely to have some of these patients who die from liver disease in your practice. So who needs screening? And again, we're screening for advanced fibrosis. People with type 2 diabetes and prediabetes are among the highest risk groups. Anyone with obesity, even without diabetes, is a potential candidate for screening. People with dyslipidemia is a sign of liver disease and also a cause of liver disease. So there's some reverse causality there. High blood pressure can also be a sign and a contributor, and age over 50. There's correlations both ways. That is, in people with type 2 diabetes, they have twice the risk of liver fibrosis of someone who does not have type 2 diabetes. And also in people with liver disease, they're much more likely to get type 2 diabetes. Both goes both ways. Causality goes both ways. So how do we screen for liver fibrosis? The strategy that's recommended in the ADA consensus statement on MASLD is that we start with a FIB4 calculation. What is a FIB4 calculation? It is a pretty simple index that has 4 inputs: patient's age, their AST and ALT, their liver function tests, AST and ALT, and a platelet count. And I'll show you the formula in a second. But if you have an age, an AST, an ALT, and a platelet count, you can pretty quickly and pretty easily calculate a FIB4. One thing we found in population level implementation efforts to do FIB4 calculations for all our patients with type 2 diabetes is that we don't always have platelet counts, and we don't always have AST and ALT. To get an AST or ALT, you need to order liver function tests or comprehensive metabolic panel, and that is not a standard lab that gets ordered for patients with diabetes. To get a platelet count, usually that comes off of a CBC panel, and while CBCs seem to be ordered on everyone, it's shockingly absent frequently in patients with diabetes, unless they have other blood or anemia issues. So in order to do population level screening for advanced fibrosis in patients with type 2 diabetes, we need to get everyone to start ordering once a year, along with their lipid panel, along with their kidney monitoring, along with their hemoglobin A1C, to be adding a CBC and a comprehensive or liver function testing panel to get these numbers to be able to calculate a FIB4. Let's assume we've calculated a FIB4 on a patient. I'll show you how to do that in a minute. But for now, the basic idea is that if the FIB4 number comes out less than 1.3, the patient's at relatively low risk of having advanced fibrosis. So their liver is relatively healthy, and they do not need to be referred for further testing or for any kind of hepatology evaluation, but they do need to be followed. The current guidelines suggest every 1 to 2 years. That is probably a little bit excessive, but there's no real data to say how frequently we should be testing them. There is some data that up to 5 years after a FIB4 under 1.3, there's no increased risk in liver-related morbidity. I think 2 to 3 years is probably a reasonable range, but again, that's a data-free recommendation. If the FIB4 calculation is greater than 1.3, that puts a patient in an intermediate or high risk group, and that needs a second tier of evaluation. So before we get to that second tier of evaluation, let's talk about the actual FIB4 calculation. Here's the formula. It's actually a relatively simple formula. You could do it on your calculator if you wanted to, but that seems kind of irritating. So there are ways to get it done more easily than that and more efficiently that we're going to talk about. But if you don't order a CBC and LFTs are comp, you won't have the data to fill in this calculation, and you will not be able to calculate a FIB4. Most of the time we know what our patient's age is, so that's not the problem. This is MD Calc. It's a website freely available to everyone. It's a very easy way, very nice form to fill out to calculate your FIB4 for you. Pop in the age, the AST, ALT, and platelet count from your EMR data, and hit calculate, and it'll tell you exactly what the patient's FIB4 is, and then you can go from there. It also nicely gives you a summary of what your FIB4 numbers mean and what should be your next step. So if it's less than 1.3, it'll say low risk for fibrosis. If it's more than 1.3, it'll recommend further testing. So we've also managed here at Care New England to embed a FIB4 calculator into our Epic installation. So we have a flow sheet, an Epic flow sheet that pulls automatically the last AST, the last ALT, the last platelet, and then allows you to calculate a FIB4. And then we have a dot phrase that we stick into our note that expands and pulls in the FIB4 calculation and the numbers that were used to calculate it, and then gives a little bit of an interpretation in your note as well. So that is a possibility. I mean, it's not super elegant. You still have to go to the flow sheet and tell it to do the calculation, and then you still have to put the dot phrase into your template or something like that. But we're trying to get this to be done on every patient with diabetes and obesity in our practices. So we already talked about what happens when your FIB4 is less than 1.3 and more than 1.3. Let's talk about if it comes out to be more than 1.3, what's the next step? Go back to low risk people first. Just because they're low risk doesn't mean you don't do anything. We have to focus on prevention for the low risk group. The best diet that's been described for preventing progression of liver disease is Mediterranean diet. That has the most evidence. Daily exercise, even the standard recommendations of 30 minutes, has a big impact on liver health. But then probably the most important thing that we can do right now is aggressive treatment of metabolic disease, weight loss, and type 2 diabetes. So get the sugars under control, get the weight down, and that is the one thing that seems to consistently protect and even reverse fibrosis. There's a bunch of things that we can do to prevent other diseases or other toxicities to the liver that may make MASLD worse or fibrosis progress more rapidly that we need to pay attention to as well, not just the diabetes issues. And then a recheck of FIB4 in 2 or 3 or 4 years, whatever you decide is the right number for you without the data. So on the high risk group, over 1.3 on your FIB4, we have further risk stratification. So the typical way that would go is if you have a greater than 1.3, you order a FibroScan. A FibroScan is actually a brand name liver elastography or liver stiffness test. And that FibroScan is something that can be done relatively quickly, and usually it's an add-on to a liver ultrasound. It gives you back a number which is how stiff the liver is. If the stiffness of the liver is less than 8 from your FibroScan, that's a low probability of advanced fibrosis. Again, back into the low risk group, regular FIB4s, and follow with FibroScans as needed. If the liver stiffness is greater than 8, that represents a high risk of clinically significant fibrosis. And at that point, we're saying that they actually have advanced fibrosis that puts them at risk for things like hepatocellular carcinoma, makes their diabetes harder to manage, and may eventually progress to full cirrhosis and liver failure. And our guidelines recommend that at that point you engage a specialist. Sometimes it is hard to find a specialist for hepatology. Here in Rhode Island, we have very limited options for how to get a patient into a hepatologist. Our GI docs do what they can to help us, but a lot of this ends up being managed in the primary care offices. And there's a lot that we can do, fortunately. So we keep doing that, what we can. Now, there are some people at high risk who do not need FibroScans, but often we just use this 1.3, less than 1.3, no FibroScan, over 1.3, you do get a FibroScan. But if your FIB4 is really high, if your FIB4 is over 2.67, that's a very high risk for advanced fibrosis. And the guidelines actually suggest that if you want to, you can say, we don't really need the FibroScan to confirm advanced fibrosis. We're using the FIB4 to say this is probably advanced fibrosis and going straight to the referral if you have that option. But for many people, that the FibroScan will confirm before they do that referral. So here's the full algorithm of what we just walked through. So anyone with type 2 diabetes, anyone with prediabetes, anyone with obesity, and at least one additional cardiovascular risk factor can get a FIB4 calculated if you order the ALT, AST, and platelets. If that FIB4 comes out less than 1.3, low risk of cirrhosis, do all the things we can do to manage their diabetes and prevent progression of liver disease. If their FIB4 is greater than 1.3, then we have a little bit of an option. We can choose to get a liver stiffness test, a FibroScan, or we can choose, if it's very high, over 2.67, to send them directly to a liver specialist, if that's an option. All right. So what happens if somebody does have advanced fibrosis? All of the usual lifestyle, diet, and exercise interventions apply here. We've had Mediterranean diet, ultra processed foods should be minimized, and there's a particular risk of high fructose corn syrups and added sugars for liver disease. Physical activity, again, the usual aerobics, 150 minutes moderate intensity per week, and resistance training as well to prevent sarcopenia that's associated with liver disease. And even without weight loss, we know that exercise improves liver fat and insulin sensitivity. So all these things become really critical when people start to advance through the MASLD, MASH, advanced fibrosis, cirrhosis continuum. Medications, there are 3 medications that have been proven to reverse and prevent progression of fibrosis of the liver in MASLD and MASH. The GLP-1s and the dual GIP-GLP-1s, so semaglutide and tirzepatide, both treat type 2 diabetes and reverse fibrosis of the liver with weight loss. Pioglitazone is another diabetes medicine we don't use very often, at least not in my practice. And the reason we don't use it very often is because it got associated with heart failure. But the heart failure literature may be a little bit over exaggerated. It may not be as risky for heart failure as we thought it was. Another drug in the same class as pioglitazone is very high risk for heart failure, but pioglitazone itself has a lower risk for heart failure, although it still seems to be somewhat risky for heart failure. Pioglitazone is the one drug that we have that has very strong evidence for reversing advanced fibrosis in liver disease. And it is a favorite drug of the hepatologist. So you will see your patients come back from the hepatologist on pioglitazone pretty frequently. It's also the drug that I've turned to when my patients with fibrosis cannot take a GLP-1, which is not as rare as you might think. So if a patient has type 2 diabetes, they can't take a GLP-1, pioglitazone is a good alternative. It's actually pretty good for managing their sugars. It's good for protecting their liver. If the patient has heart failure and diabetes and liver disease, pioglitazone is probably not a great option for them. and it could increase the risk of a heart failure-related hospitalization. Other treatments for diabetes, like SGLT2 inhibitors, metformin, DPP-4Is, these drugs don't have great evidence for improving liver disease, although newer trials on the SGLT2 inhibitors are a little bit more promising. They don't do the same amount of improvement that we see with these other drugs. There are some specific drugs that are just for fibrosis, and as resmetirom is sort of the big one that the hepatologists are all excited about. A lot of new data suggesting that resmetirom is very good at stopping progression of fibrosis in these patients, particularly when they're sort of in the early advanced fibrosis stages of F2 or fibrosis stage 2, fibrosis stage 3. So moderate, early or moderate advanced fibrosis. This is not a drug that I've ever prescribed as a primary care doctor. This tends to be something that is prescribed currently by GI docs and hepatologists primarily. It's pretty expensive. It does have, it has some interactions and some things you have to check before you do it, but they no longer require a liver biopsy before initiating it. So it is something that potentially somebody in a primary care office could initiate if that was the best option for the patient. Ketogenic diet, one of the things that MCT2D talks a lot about is ketogenic or low-carb diets. And ketogenic diets, there is actually some data that ketogenic diets help reverse MASLD and MASH. There's not a lot of data. It's fairly limited. Definitely decrease intrahepatic fat storage. Definitely see improvements in liver function testing and insulin resistance and histology when we actually do biopsies. And it seems to be primarily related to the weight loss. So presumably if you did a ketogenic diet and didn't have significant weight loss, you might not see the benefits. But really just about anything that causes significant weight loss is going to improve steatotic liver disease. You guys probably know more about low carbohydrate diets than most people, but there is some concerns about monitoring for cholesterol, LDL, particularly elevations, and there's very limited long-term data on fibrosis regression in MASLD and MASH yet, although a number of trials are happening right now. So that was sort of the whole focus of MASLD, but we're going to shift the second half of the talk to the other things that can basically synergistically accelerate the progression across the continuum of liver disease. And these are things that everybody has a role, whether you're a dietitian or a primary care doctor or an endocrinologist. You have a responsibility for thinking about these other things that may be accelerating liver disease in your patients. And the first one is the biggest, most frequent one is alcohol and metabolic dysfunction related to diabetes. So first of all, we know that if you already have metabolic dysfunction related to your diabetes and obesity, the risk of progression to fibrosis is pretty high with a relatively low or moderate alcohol intake. So that what we're calling moderate alcohol intake is 1 to 3 drinks a day for women and 2 to 4 drinks a day for men. That's pretty common in today's world, in the US at least. And many of our patients with diabetes have at least 1 drink a day, if not more. So we have to think about alcohol-related liver damage in these patients, even though they may not drink enough to consider themselves or to be considered a hardcore alcoholic. They may be damaging their liver, and in combination with the MASLD, it's probably a pretty toxic combination for the liver and accelerating the progression. So the important thing about alcohol is that alcohol use disorder is common and it is treatable. In the old days, we used to focus a lot on the 12-step programs and counseling, and not very many people got better. And we got a little bit complacent and a little bit thinking that there was nothing we could do. If people were going to drink themselves to death, there's nothing we can do. But that's not true anymore. Just like there are really great new drugs for diabetes, like the GLP-1s and the SGLT2 inhibitors, there's some really great new treatments for alcohol use disorder that are very effective, even in people who've been uh, uh, abusing alcohol for decades. And so if you have a patient with MASLD, it's really important, or just diabetes, it's really important to ask about alcohol. Patients can lie about alcohol, but most of the time when you ask them directly, they'll give you a pretty honest answer. There are blood tests for alcoholism, chronic alcohol use. I don't use those blood tests very often in my practice, but some people say that you'll find a lot more patients with alcohol use disorder that using blood tests. Patients not willing to talk to you about their alcohol use disorder, it's going to be hard to get them treatment. So I'm not sure that's that helpful, but maybe just knowing that they're a higher risk is useful. Consider behavioral therapy. So yeah, referral to counseling, substance use disorder treatment programs, whatever you can find for that. But the easiest, most obvious, and most underused thing we can do for people with alcohol use disorder who are trying to quit and struggling with it is naltrexone. So there's naltrexone 50 milligram PO tabs that you can give daily. The naltrexone PO tablets are pretty effective for people with the 1 to 3 drinks a day chronic use who are having trouble cutting down. And they may not consider themselves to be severe alcoholics, but they just want to quit and they can't. They find themselves every night drinking 1 or 2 drinks. The heavier drinkers, the people who've been drinking for longer, people who stop taking the naltrexone so that they can enjoy their drinks more, people who are less organized and have more executive function problems. There is a long-acting injectable form of naltrexone called Vivitrol. It's a monthly injection. It's much more effective in my patients, I found, than the naltrexone oral for the more severe alcoholic patients. But it's really astonishingly effective. I have a number of patients in my practice who have gone from being regular daily heavy drinkers to being completely abstinent for up to 1 or 2 years with Vivitrol monthly injections. They're expensive. It's hard to get prior auth, but for patients that are in and out of the hospital because of their alcohol use disorder, Vivitrol is cheaper than recurrent hospitalizations. Camperol is another drug that is very effective for alcohol use disorder. The main downfall for Camperol is that it's actually 2 tabs for 3 times a day. So it's 6 tablets a day, and patients get a little overwhelmed with that. So we say 2 tabs with breakfast, 2 tabs with lunch, 2 tabs with dinner every day. That's a lot. People don't like it for that reason alone, but it actually seems to work pretty well for alcohol use disorder reduction. It's particularly good when you cannot use naltrexone, and that would be anybody who is using opiates, Suboxone, fentanyl patches for other medical problems that would be a contraindication to Vivitrol. So remember that we have really effective tools for treating alcohol use disorder. Remember to screen for alcohol use disorder. And then the last thing I will say is that these drugs are so effective at stopping alcohol use disorder that you will sometimes frequently find a patient who was self-medicating for a mental health disorder with their alcohol, and you will be able to get them to stop using the alcohol, but you won't have done anything to treat the underlying mental health problem, which will then rear its ugly head and cause more problems until the patient stops coming in for their long-acting injectable naltrexone and starts drinking again. So it's pretty important, if you're going to attack alcohol use in these patients aggressively, that they have mental health care available, aggressive mental health care to deal with the underlying problems, whether it's PTSD or depression or anxiety or serious mental illness. Those things all need to be dealt with pretty aggressively when the alcohol is successfully removed. Hepatitis B and C in patients with MASLD dramatically increases the risk of progression to advanced fibrosis. It's something we can do. It's something we have tools to treat and prevent. So screening everybody with type 2 diabetes who we think probably has MASLD should probably be screened for Hep B and Hep C. These are somewhat universal recommendations, even if you don't have MASLD, but really important in people who already have another risk factor for liver disease. So we make sure we check for different varieties of carrier status or previous exposure, previous vaccination in Hep B, and then the anti-HCV antibodies as well. If they do have the HCV antibodies, you want to confirm with HCV RNA and quantitative and see if it's active or not. And then if it is, it needs to be treated. We know that if they have active hepatitis C or active hepatitis B, that dramatically accelerates fibrosis progression in MASLD. So they need to be treated. Both Hep B and Hep C now have effective treatments, and Hep B has a vaccination. So for anybody who has no previous exposure to hepatitis B, who has a negative serology for hepatitis B antibodies, they should be vaccinated if they have MASLD or just if they have type 2 diabetes and obesity and are at risk for MASLD. If they have advanced fibrosis, they definitely need to be vaccinated in Hep B because the combination of Hep B and advanced fibrosis is deadly. Again, after appropriate treatment for Hep B and Hep C, and after vaccination, you can check for titers again, make sure they got immune. After treatment, they need to be retested and make sure they have completely cleared the virus. Again, for Hep C is treatable now. We used to have treatment, but it wasn't that great, and it was really unpleasant. Had lots of side effects. Lots of people couldn't do it. Now our Hep C treatment is excellent. We have a number of different options for hepatitis C treatment. They're expensive, sometimes hard to get prior auth, but they work really well and they reduce the risk of advanced fibrosis. One of the things that we often forget to talk about in our patients who have MASLD and liver disease, advanced fibrosis, cirrhosis is what to do about minor aches and pains. As a general principle, because we're all trained that Tylenol causes, like Tylenol overdose and fairly low levels of Tylenol can cause liver failure, that Tylenol is bad for your liver. And you shouldn't, anyone who has MASLD, has advanced fibrosis, cirrhosis, should not be taking Tylenol. But the alternative to Tylenol is NSAIDs, and NSAIDs are worse for liver disease. So most hepatologists recommend basically Tylenol is better than NSAIDs, safer than NSAIDs for your liver, but you should limit it to 2 grams a day instead of 4 grams a day, which is the typical limit for Tylenol for someone who doesn't have fibrosis or cirrhosis. And of course, if they have uncompensated acute liver failure or very heavy alcohol use, the Tylenol probably isn't really an option either. And again, shorter term, lower dose use is probably fine for most people with cirrhosis and advanced fibrosis. NSAIDs, not so much. You really want to avoid those in cirrhosis. They cause all kinds of problems with GI bleeding, kidney problems that can cause hepatorenal syndromes. And if you want to use them in early MASLD, that's probably okay. But again, lower dose, shorter term use if possible. Hepatocellular carcinoma screening in patients with cirrhosis. So let's say you've got a patient, you screen them for FIB4, they were high, above 1.3, you got a FibroScan, they had a high 15 on their FibroScan liver stiffness measure, and that puts them in the cirrhosis range. You've referred them to hepatology, and the one thing that needs to happen if they're not getting it through their hepatologist is they need to be screened for hepatocellular carcinoma, which is a very high risk cancer that comes with advanced fibrosis and cirrhosis. And the typical recommendations for screening that rarely happen, but is what's recommended, is every 6 months ultrasound plus AFP lab. So those 2 things, it's pretty hard to get somebody to get a screening test every 6 months. That involves going into get it into a imaging location. But I think if you manage to get it once a year, you're probably doing better than most practices. Most people with cirrhosis and advanced fibrosis are not getting any surveillance protocols at all, and many of those people do end up with later stage diagnosis of hepatocellular carcinoma without good options for intervention. So I just wanted to bring back this slide from the beginning where we talked about MASLD, which is 70% of people with type 2 diabetes have already signs of steatotic liver disease. MASH, which is steatohepatitis, so a progression from MASLD where there's inflammation and starting to see some liver damage, advanced fibrosis, cirrhosis, and hepatocellular carcinoma. That's the progression we're trying to stop. And it is a significant burden in our diabetes patients that we have lots of strategies to mitigate. And then this is my last slide, and it's just top 10 actions for MASLD and type 2 diabetes. These are orders that a physician can write or treatments that can be recommended for a patient with type 2 diabetes that actually slow the progression of MASLD to advanced fibrosis and hepatocellular carcinoma. So biggest, semaglutide and tirzepatide, our GLP-1 friends that cause weight loss and reduce hepatic steatosis. Pioglitazone if the patient doesn't have heart failure, especially if they can't tolerate a GLP-1. If they have even moderate daily alcohol use, oral naltrexone, or more severe alcoholism, consider IM monthly Vivitrol. If they're not immune to Hep B, they need a Hep B vaccine. For everyone, if you're monitoring for progression of fibrosis, you need to be able to calculate your FIB4, and it looks like I dropped off the LFTs on here. You need your CBC and your LFTs to be able to calculate your FIB4. You need your hepatitis B screening, your hepatitis C screening, an alpha-fetoprotein for hepatocellular carcinoma screening, your FibroScan for risk stratification in patients with a high FIB4, and your ultrasound, liver ultrasound to screen for hepatocellular carcinoma every 6 months in patients who've been diagnosed with cirrhosis. And that is my entire summary of what's in the new guidelines for MASLD for patients with type 2 diabetes. And I'm happy to take any questions.
Thank you so much, Dr. Richardson. There was a bunch of questions in the chat throughout the presentation. I'm happy to read those aloud, and then as people have others, please feel free to either unmute and share them or put them into the chat. The first question was, are there different recommendations based on patient age?
I would say that the main difference, there are some differences based on what are the FIB4 cut points based on patient age, and under the age of 35, it's unclear whether the FIB4 is really accurate, and over the age of 65, it's unclear whether the FIB4 is really accurate. But those guidelines are still pretty reasonable to do your screening with. And it's not like we have other better guidelines. It's just like, be a little bit suspicious below the age of 35 or over the age of 65 about your FIB4 score.
And then a second question, did you say if the FibroScan is less than 8 kPa to repeat the FIB4 in a year?
Yeah, that guidelines of how frequently we screen with a FIB4 are based on almost no data. So they're data-free guidelines. You can do whatever you want. There's no real convincing data. The one piece of data that I have seen on that is that the risk of progressing to advanced fibrosis, if you have a low FIB4, within the next 5 years is pretty low. So you're actually pretty good for about 5 years, but you wouldn't want to wait much longer than that. The guidelines actually say every 1 to 2 years, but that is, again, a data-free recommendation.
Then if the patient has an ultrasound on file that's indicative of, sorry, I'm probably going to mispronounce this, steatosis, would you still follow the same process?
Yeah, Absolutely. I think so the ultrasound, there's two things you get out of an ultrasound. Well, there's a bunch of things you get out of an ultrasound, but the liver stiffness is a measure of fibrosis, not of how much fat is in the liver, which is the steatosis. So the ultrasound can give you an estimate of how much steatosis there is. It's an additional test with an additional piece of equipment separate from the regular ultrasound that gives you the liver stiffness. The FibroScan is it's a separate add-on to the ultrasound. And the FibroScan is much better at detecting early and advanced fibrosis than just looking for steatosis. So the steatosis doesn't really give you a difference between fibrosis and just fatty accumulation. But if you saw fatty accumulation, that is essentially MASLD. That's by definition MASLD on an ultrasound. And getting a FibroScan, getting a liver stiffness test, getting a FIB4 would be useful at that point.
Next one, does resmetirom work in liver fibrosis irregardless of the cause?
It does. It is something that all the hepatologists are using for whatever is causing a liver fibrosis. Although the most common reason they're using it for right now is MASLD, because there are other things that they can do for other causes of fibrosis, for most other causes of fibrosis.
Okay, and someone had asked in the chat, and it was confirmed that, of course, this is a risk if a patient's on SGLT2 and a keto diet, the risk for euglycemic DKA. I don't know if there's anything you want to expand on with that and the risk related to that.
Yeah, I will say that your liver is really important for protecting against hypoglycemia. Its entire job, its entire metabolic job, is to protect against hypoglycemia, severe hypoglycemia. And so euglycemic DKA is a risk in SGLT2 inhibitors on a keto diet because of the low carbohydrate load. And if you further impair the liver's ability to manage that hypoglycemic postprandial state, you further increase the risk of a potential euglycemic DKA. So the more damaged the liver is, the higher risk of severe hypoglycemia postprandially in a patient who's having has risks of potentially a euglycemic DKA from an SGLT2 inhibitor. So that is an increased risk. There's no question about it.
Next question, do you avoid pioglitazone altogether in heart failure patients, or do you consider it in patients that are not NYHA class 3 or 4?
I avoid pioglitazone when I can, and I only really honestly consider it when the GLP-1 isn't an option. And if a GLP-1 isn't an option, then it's sort of a case-by-case basis, because there aren't a lot of other treatments that can really protect the liver other than pioglitazone. And I think I would be willing to try it in a early heart failure patient and monitor very closely if that was really their only option and they were aware of the risk and willing to go along with it. But it is a tough sell for somebody with known diagnosed heart failure to start pioglitazone.
And the next, do you ever use disulfiram for AUD?
I don't. I find the Vivitrol and the oral naltrexone to be so effective, and I find that patients really don't like the idea that if they drink, they're going to get really sick. They just don't take it, and the naltrexone doesn't have that same effect, and patients are more willing to take it, and it seems to be more effective.
Great. The next are vitamin E supplements effective in MASLD?
There's no data that suggests that vitamin E supplements are effective in MASLD, although there was some early data that showed that. I don't think it's panned out in major clinical trials. It was not one of the recommended, at least the liver disease consensus panel did not agree to put it in there as a recommendation.
And then who did you say should be screened for HCC every 6 months?
Anybody with cirrhosis, whether it's from alcohol or from metabolic disease or from anything else. Hepatitis C is another common cause of, and hepatitis B, common cause of cirrhosis. anyone with a diagnosis of cirrhosis is supposed to be screened with surveillance studies for prevention of hepatocellular, not prevention, but early detection of hepatocellular carcinoma. Every 6 months, 2 tests, an ultrasound, and AFP lab.
And going back to an earlier discussion, so is there a role for ultrasound in assessment, or is it reasonable to skip it and just do FibroScan?
Great question. So it's a little bit complicated. I think so. The FibroScan, if you have the right tool on your ultrasound machine to do the FibroScan is very quick. It's a very simple test. It's lower cost than a full right upper quadrant ultrasound imaging test. I think the FibroScan itself is a pretty good screening test. The ultrasound is not a great test of fibrosis. So the FibroScan wins on cheaper, faster, better test for fibrosis, which is really what we're looking for. But there are some exceptions, and you don't always know if it's an exception or not. Because the FibroScan is testing for liver stiffness, there are other things besides fibrosis that cause liver stiffness. For example, a hepatocellular carcinoma is very stiff. And so if your patient already has hepatocellular carcinoma, you will get a high liver stiffness score. And you may not notice that the patient actually already has hepatocellular carcinoma. Whereas if you got that ultrasound first, instead of getting the FibroScan, you would see the hepatocellular carcinoma on the ultrasound. So many people and many order sets in EMRs are basically right upper quadrant ultrasound of the liver with a FibroScan and just get both. But technically, the screening really only requires the FibroScan.
And then next question, what is the significance of FIB4 that is abnormal in patients without obesity and prediabetes?
Oh, that's a good question. And I don't honestly know the answer because we don't typically calculate a FIB4 in patients who don't have diabetes or obesity. That is not a question I know the answer to, but we can look it up and try and get back to you on that one.
And then last question that's currently in the chat, since GFR is automatically included with the lab as a measure of kidney function, why not have the lab automatically include a FIB4 calculation in patients with type 2 diabetes or prediabetes?
Yeah, we would need to order a CBC and liver function test to get them to automatically do it. But it does seem like that could potentially be automated. If anytime a CBC and liver function tests are ordered together on the same day, you could potentially have them calculate a FIB4 automatically. That would be a great addition to liver screening.
All right. Any final questions from anyone? No? Dr. Richardson, is it okay for us to share these slides out with the collaborative? We've gotten a lot of requests for the slides.
Sure. Absolutely.
Right, great. And thank you so much for your time today. Clearly, this was highly valuable to the collaborative, lots of questions, and we really, really appreciate you sharing this with us.
Sure. Thanks for having me. And I'm so glad to see that MCT2D is still going strong.
Absolutely. All right. Well, thank you, everyone. Hope you have a wonderful afternoon. We'll send out the slides and the information, everyone. All right.
Thanks. Bye.
Thanks so much.